So the other things we think about is the non-cognitive, and these are the things that are probably more distressing for Alzheimer's. You get an apathy. You know that they have a blank look to them. They don't have facial expressions. They don't seem like they have big swings in their emotions. We see a higher incidence of depression. We do see hallucinations with Alzheimer's, but I would argue if you see a lot of hallucinations, you want to be thinking of a different disease such as Lewy body or something else going on. You don't want to be thinking about Alzheimer's, especially early on. It's not a classic feature. We can see it, but we see it more in the moderate severe stages. Anxiety, we see a lot of anxiety because they're not aware of their situations, which obviously is anxiety provoking. And then we get some delusions. And the delusions can be rather fixed. And the one thing for caregivers is you can't talk somebody out of a delusion. And there's just no point in trying. And I think about a patient, a husband and wife I took care of at Terracina Grand. The wife had Alzheimer's and the husband didn't. And the wife kept on looking at their marriage picture and saying, "You're not my husband, this is my husband." And what she remembered, her short-term memory was impaired, but she realized that's my wedding picture, that's my husband. And then she looks at this old guy and says, "Look, you ain't my husband, this is my husband." And you could try to convince her any way, shape, and form. It just doesn't work, and it's not worth the effort. So what do you do in a case like that? Do you medicate them? No. You get rid of the photograph. And unfortunately, all too often, we medicate. But there are simple solutions to these delusions. But don't go down the path of trying to explain it over and over and over again. It's not going to work. And even if you get all the way through the delusion and they agree with you, be prepared to do it all again in 15 minutes. And it's just not worth it, and it leads to increased agitation. And most of the time in dementia, the agitation can be taken care of behaviorally. Sometimes, especially with the frontal temporal dementias, it's a little bit harder. And then commonly we see sleep disorders in dementia. And this is really a big thing because we get the phone calls all the time from the assisted livings when people mix up their days and nights. And they call me for the magic pill. And there is no magic pill. If you mix up day and night such that you're awake all night long, the caregiver's exhausted. So what do? They let you sleep all day. And then it repeats the cycle. And what you need to do is when the sleep-wake cycle gets mixed up, you really have to keep them up all day. So even if they were up all night, and I got to tell you, it's brutal. I went through this with my wife's grandmother, and she had it all mixed up, and I sat there for 12 hours keeping her up, and literally by around 5, 6 o'clock, I don't know who wanted to kill who more. But it's tough because every time she'd fall asleep, I'd wake her up, and then she'd curse me out in Spanish, and then I'd get mad, and it was just, it's endless. But if you do that, the next day they sleep. There's no sleeping pill that's going to work if they slept all day. And so a lot of times if you're the caregiver and you're exhausted, it pays to just bring a caregiver in with the sole purpose of keeping them awake for that 12, 24-hour period so you could reset the cycle. You do that, then they're fine. But you can't start drifting back into the habits where let them sleep 3 or 4 hours during the day, I'll get some things done. It really messes up the sleep-wake cycle. All right, so the pathology of Alzheimer's disease you've heard me talk about before. It's basically plaques and tangles. And this is the thing that I said, may be true, maybe not true. Because we've known for years that in Alzheimer's disease you start making plaques. And we've actually developed PET scans that could stain the plaque, and we could identify who's going to get Alzheimer's probably now 10, 15 years beforehand. And there was just 2 large trials done with antibodies against the plaques. And when I say just done, published about 2 weeks ago. And there were 2 different molecules designed to prevent the plaques. And we actually saw some of the plaques disappear, but unfortunately we didn't see any improvement in memory. And it's really questioned whether this whole theory about the plaques is where we should be. And for those of you who've been hearing me talk about this for 10, 13 years now, I've always been more of a tangle kind of guy. And I was always concerned that all the research was being done on the plaques. And it's kind of, the plaques are in your face. There's so many of them. They're easy to think about. But they may be so far downstream that the process that we got to prevent is way up there. And that's one of the biggest concern that we're seeing. So how does a physician diagnose Alzheimer's? And we do screening tests. The classic one is the Folstein Mini-Mental. The doctors give this in the office. It's a 30-point test, and it checks orientation. There's some visual spatial, there's some language. It's a good test to follow every year. It's a poor test to diagnose Alzheimer's. It does no executive dysfunction. It does no frontal lobe. But it's a good screening test for physicians because it's quick and it gives you an idea if there's a problem there. The clock drawer is one of my favorites, and it's amazing how hard it is to draw a clock and set all the numbers and then set the time at 10 after 11. It's really a hard task. And unfortunately, 50 years from now, we're probably never going to be able to use it because these kids don't know how to tell time anymore. Everything's all digital. But right now, it's a great test. And for anyone who's doing a clock, I always say, you got to draw a big circle, and you encourage them to draw a big circle. If you draw a small little circle and you start at 12, 1, 2, you may end up in the right place just because the circle's so small. If you put a big one, then it has to be planning, and there's a lot to be learned. You watch how they plan, how they do. They know the difference between a small hand, the big hand, and so it's a great way. I almost always do neuropsych testing, and I refer people out for that, and that's more an extensive testing. And I don't do it to diagnose Alzheimer's because the diagnosis is usually pretty clear. I do it to see if there's any strengths or especially weaknesses. Because if somebody has a lot of strengths, their visual memory is real good. Well, then you write everything down, you put calendars. If somebody's visual memory is really impaired, well, then writing calendars and everything down is not very good. So there's a lot of valuable information that's in the neuropsych testing beyond the diagnosis. So this is the amyloid precursor protein, and this is the protein that gives rise to the plaques. And so when I first started talking about this, we used to talk about an enzyme that cleaves here, and an enzyme that cleaves here, and then one that cleaves in the middle, and they were all theoretical. And that was in 2000. And then we identified the enzymes, and we've named them beta and gamma secretase, and then we've actually developed drugs against it, so that in theory, we'd be able to prevent these, which is the plaques we see with regard to Alzheimer's disease. And those studies just haven't, been fruitful. And there's some people who come up with all these reasons about why it was started too late, and there's a soluble amyloid and there's an insoluble amyloid. But is anyone here a Red Sox fan? All right. So if you study Alzheimer's, it's like being a Red Sox fan before 2004. You think we're going to win, and then they let you down. And that's what the Alzheimer's is they get your hope up. We got these drugs, they're coming, and then the studies come out and they don't work. And then you question, maybe we're wrong about the whole pathology, and that's kind of where we are now. So that protein basically forms together, and this is what forms the plaque. And so they developed antibodies against the plaque. And the body cleared it. The antibodies lined, they jumped onto the plaque. Microglial cells, these macrophages in the brain came and they cleared the amyloid. And if you do a PET scan, you see them going away. And there's markers in the cerebral spinous where you could measure tau and see something. And we see them all heading in the right direction, but we don't get the benefit. And so, and again, this was 2 drugs, with similar mechanisms. So then you're saying to yourself, maybe we're too late, but it's really questioned what we're trying to do. So I've always been a tau man, and the tau is basically the railroad tracks that hold the cytoskeleton together, and they get too much phosphate on them. And when they get too much phosphate, everything starts to fall apart, and then they form these tangles. And when they form the tangles, that's basically what happens is when the cells start to die. And not all plaques are the same. There's what we call diffuse plaques, which are plaques that don't have any inflammation, and there's neuritic plaques, which have inflammation. And the neuritic plaques are the ones that cause the cell death. And so it may not be the amyloid may be the end result of something else. And the something else, unfortunately, we don't know about.